Okay, good evening, everyone. Thank you for joining us today. Apologies for the delay in starting the session. Just for confirmation, the session is supposed to be starting at 6 p.m. and not 7 p.m. as our usual webinars. So as we wait for our colleagues to join, I'd like to just ask you to kindly go to the PPB portal and ensure you subscribe to this event. So you'll just find the name of the event, Written Community Pharmacy Model for Dispensing ARVs. We will be starting shortly. So as we wait for our colleagues to join in, kindly ensure that you subscribe to the event on the PPB portal. All right, so I think we'll just get started as we wait for more of our colleagues to join us. So first, I'd like to thank you all for joining this session. I know it's usually we have our sessions at 7 p.m., but this was an exclusive meeting where we will be having it at 6, which is earlier. Thank you so much for joining. And if you've not, kindly ensure that you subscribe on the PPB portal. So for this session, we'll be having our speaker, Dr. Eric Mutua, who's from NASCOP, and he'll be presenting on today's topic on a community pharmacy model for dispensing ARVs. So without wasting more time, I think I'll just welcome Dr. Eric Mutua to take us through the presentation. Dr. Eric, if you can hear me.
Thank you, Dr. Ezron. I don't know whether I'm audible now.
Yeah. Yes, you can hear you loud and clear. Thank you.
Okay, thank you. Good evening, everyone. So we'll get started. So as I've been introduced, I'm Eric Mutua. I work with the Ministry of Health, currently at the National AIDS and STI Control Program, that is NASCOP. So today I was invited to share with us about the community pharmacy model, ARV dispensing. I have just called it a sensitization meeting, although it is not a sensitization meeting per se. We had held another sensitization meeting before. So I'll get started. So this is my outline of the presentation. We are going to do an overview of the HIV situation in the country. Then we do overview of the private sector engagement framework, the anchor document which has enabled us to be able to start the ARV distributing in community pharmacies. Then now we shall delve into the community pharmacy model itself. So allow me to start with the HIV situation in the country, just an overview. As you can see, these are the 2023 estimates. Currently, we have the country has a prevalence of 3.7%, 5.3 in females and 2.6 in males. The estimated people living with HIV in the country is around 1.4 million. Adults, that we classify adults as 15 and above. We have around 1.309. Children 0 to 14 years, we have 67,869. AYP, that is the adult young people, 15 to 24. We have 145, 142. Then adolescent 10 to 19 years, we have 88,853. On matters of new infections, all ages, you can see in the year 2023, we were at 22,154. And adults, if you segregate that according to the age, adults, that is 15 and above, the new infection number was 17,680. And children 0 to 14 years, we had 4,464. And just note that 41% of all our adult new HIV infection were occurring among the adolescent and young people, that is 15 to 24 years. So that is a very key group to us, and we are focusing on that, and we are focusing on that even on the prevention methods which we are offering. So in terms of the 10-year progress towards Vision 2030, remember in 2030 we are supposed to end HIV infections, and we have been able to reduce new HIV infections. We are at around 78.2%. Then reducing the AIDS-related mortality, we are at 68.4%. And then reducing HIV-related stigma, we are not doing very well. We are at 23.3%. And then in matters of domestic financing, we stand at 34%. Just to illustrate what I've indicated on the issue of achieving the UNAIDS targets of 95%, whereby the first 95 is about testing, the second 95 is about those who are tested to be put on treatment, and the other 95% is usually about those who are on treatment to be virally suppressed. So as indicated above, we have around 1.4 million people living with HIV in the country. As you can see, the blue indicates whatever we have been able to achieve, and the red is the gap. So in diagnosis, we have been able to do 98% of the estimates by achieving a goal of identifying 1.351541,000. And we have been able to put around 1.350 people on treatment. And among those who are on treatment, 1.2 are virally suppressed. That is the overall cascade for all ages. When we segregate according to ages and other subpopulations, we have the children. The children, we have around 67 estimated children living with HIV, 67,869. Among that, we have been able to achieve 76% in diagnosis, 76% in treatment, and 70% in viral suppression. On the adolescent, this is the AYP. This is the adolescent group. We have around estimated 88,000, and we have been able to achieve a diagnosis of 83%, treatment 83%, and viral suppression 77%. Then young adult cascade, we have estimated 145,000. We have been able to achieve 70% in diagnosis, 70% in treatment, and 64% in the viral suppression. On the adult cascade, here we have been able to do better. We have 99% in diagnosis, 99% in treatment, and 95% in viral suppression. So in carrying out our mandate and in carrying out the treatment, we have the Kenya HIV Prevention and Treatment Guidelines. 2022, we normally revise them every 2 years. So now they are under review. But you can be able to access these guidelines in our website, that is NASCOP. If you just type NASCOP and Google, you'll be able to get this. You go to the section of online resources, you'll be able to get the guideline. And the guideline, just to an overview, it has 8 components. It has a component of antiretroviral therapy, the positive human dignity and prevention, gender-based violence and intimate partner violence, and HIV education and counseling, screening for and prevention of specific opportunistic infections, reproductive health services, screening for and management of non-communicable diseases, mental health screening and management, nutrition services, and prevention of other infections. So in terms of what we are using in treatment, for all ages, you can see the first line, we are doing weight-based dosing, and the preferred first line is for birth to 4 weeks. We use the AZT, 3TC, and nevirapine. More than 4 weeks, we have those 2 regimens, ABC, 3TC plus DTG, or TDF, 3TC, DTG. And this is on the far left, you can see the dosing, the weight-based dosing. Then above 15 years, any weight, we are using the TDF, 3TC, and DTG. Second line, it is illustrated. We are using ABC or zidovudine plus 3TC plus DTG when if somebody is less than 30 kgs. Then I can move on to as indicated in the cascade there, for us to be able to see whether people have been virally suppressed, we have a schedule of how their VLs are undertaken. And as you can see, 0 to 24 years, the viral load is taken 3 months after ART initiation, and then thereafter it's done 6 months, after every 6 months. For 25 years and above, it's the first viral load is normally after 3 months after initiation, ART initiation, and then at 12 months, then annually. For pregnant and breastfeeding women, the new positives, they are treated just like the other population. That is, the first viral load is undertaken after 3 months of ART initiation and 6 months, and after every 6 months. Then pregnant and breastfeeding women who are already diagnosed. So it's usually after every 6 months. And when we are doing a regimen switch, we don't do any VL, but we do 3 months after the switch. So we have some new products which we are phasing in or phasing out. The new products we have is we have Tafel-D, that is tenofovir, alphamide, lamivudine, and dolutegravir. Now we have a fixed dose combination of bacavir, lamivudine, and dolutegravir for the children. We are having injectable cabotegravir, that is Cabele, which has come. Lenacapavir is in red because cabotegravir is a bit ahead in terms of implementation in the country. Then we have the pivoting ring. This is a vaginal ring which is impregnated with the pivoting. Then we have darunavir. And then some of the products which we are phasing out, we have lopinavir, favirenz, and nevirapine tablets. This is not the syrup, it's the tablets. So for us to be able to say somebody is suppressed or unsuppressed, these are the cutoffs. So we have two categorization in the definition of suppressed, that is LDL and low risk viremia, and the values for you to be LDL, you have to have less than 50 copies per ml. And the interpretation is that you have attained the treatment goal and you should continue with management. For the unsuppressed, the extreme one is having more than 1,000 copies per ml, and client is at risk of morbidity and mortality, and you should conduct enhanced adherence counseling, and then you repeat viral load after 3 months. And second line, if second line VL is more than 1,000 copies per ml. So now I want us to engage in the private sector engagement framework for delivery of HIV services in the country. This is a document which was developed in partnership with development partners, the private sector, and the government, that is public sector. And as you can see at the center, we have the client who is at both the private and the public are coming together to provide client-centered services. And the aim is to expand access to HIV care services through the private sector to complement what the public sector is doing. And the goal is to leverage the PPP collaboration and resources to enhance HIV service delivery and contribute to HIV epidemic control in the country. So the public-private partnership has 4 chapters. It's a document which you can be accessed through our website. It has an introduction. It's talking about increasing access to quality HIV services in the country. Chapter 3 talks about the leadership, governance, and institutional framework. And then there is awareness creation, knowledge, and information sharing. On background, it's just like I done the introduction. And the purpose of this framework was to provide an instrument to guide an enhancement of private sector involvement in the provision of quality HIV services in the country. And the goals is, the rationale for this was to enhance access to affordable and client-centric HIV services, scale up HIV services using the PPP engagement as promoted by the Constitution 2010 and the Universal Healthcare Agenda, and collaboration. This enhanced collaboration will lead to minimization of implementation and service delivery challenges, and it will also create innovative mechanism to mobilize financing modalities for the HIV services, and it will be able to contribute to the meeting the global UNAIDS global targets of 95, 95, 95 in ensuring we eliminating HIV epidemic by 2027. So what is the implementation approach? The implementation approach is number 1, to ensure we have affordable HIV prevention, care and treatment services. And this is through the partnership with private health sector to provide HIV services to referred established recipients of care. Here we are not referring to the people living with HIV as patients. The UN AIDS guides that we can use some common terms which are acceptable to the patients, and this is the recipient of care. This is what you shall see as you see in the whole document, abbreviated ROC. And then number 2 is to ensure we have access to health products and technologies for HIV services. Initially, the government will be able to supply ARV and selected OI medication for dispensing. And in future, there is envisionment that there shall be an establishment of a pooled procurement mechanism for private health facilities to access affordable products. And then number 3 is to ensure we have access to laboratory services for HIV prevention, care, and treatment. What the document envisions is about sample collection by private sector entities for processing in public health labs, and then by strengthening the laboratory networks. So the strategic objective number 1, the issue of increasing access to affordable HIV prevention, care, and treatment. It has some specific objectives, and this is what we are really dwelling on in this part of implementation of this private sector engagement framework. The framework outlines the client pathway for comprehensive services. As you can see, we have the community services, the public facility, the private hospitals and pharmacy. Then there is a referral for patient for review, and there is referrals for ARV refills. Then we have access to the community. They will be able to access HIV self-testing, PEP, and PrEP. So this is the commodity supply pathway, whereby we have a pooled procurement mechanism, and the products, commodity and supply orders will be able to flow bi-directionally. Then for the laboratory services, the same just as the way the other commodities will be able to flow. And this is how we envision the implementation matrix shall appear when we shall have pooled procurement, whereby we shall have KEMSA and either faith-based pooled procurement agency, and they will all be able to supply to the public health facilities or FBO health facilities, and then the FBOs or the FBOs will be able to supply to private health facilities, and the public health facilities will be able to supply to retail and community pharmacies. So now we delve into the community pharmacy model. So under community pharmacy model, I would like us to look at the differentiated service delivery models, the rationale, the HIS, that is the health information system, and data privacy and confidentiality. So what is a differentiated service model? According to WHO, it is a client-centered approach that simplifies and adapts HIV services across the cascade to reflect the preferences and expectations of various groups of people living with HIV, while reducing unnecessary burdens on the health system. So these are the DSD models which we have. We have facility-based DSD models and community-based DSD model. At the facility, they implement a more intense and a less intense. And more intense is where there is offering of standard of care. It's made for adult and young people, child caregivers, pregnant and breastfeeding. While the less intense is the fast track, whereby a recipient of care gets a prescription. Once they visit, they go to the clinician, get a 6 months prescription, which is refilled after every 3 months. So the first time they are in the facility, they are provided with the 3 months dose. Then after they finish, they will not come back to the clinic, and they just go straight to the pharmacy. Then we have the community-based model, whereby we have the CAGs, the community RT groups, and then we have the community RT distribution points. This one has not been activated in the country. And then now we are having the community pharmacy, and then individual RT distribution, whereby somebody can have their medication delivered to them either through online pharmacies or through Uber. It's what we refer to the ART distribution. So community pharmacy model is, we have seen it's a form of a DSD model. And as you can see, these are the anchor documents which have enabled us to be able to implement this. We have the UN AIDS fast track targets 95, 95, 95. This is what we are raising to achieve. Then we have the Kenya AIDS and Strategic Framework, that is the CAS 2, which will expire in 2025. And then we have the private sector engagement framework, and the community pharmacy model is at the center. So what is community pharmacy model? And these are form of DSD, whereby established recipients of care will pick their ARV medication from private pharmacies. It is client-centric and aims to offer convenience to clients and also decongest public health services, thus enhancing the quality of service delivery. And as we have indicated, it is embedded fully in the private sector engagement framework that underscores the public-private partnership collaboration. So why should we have community pharmacy model with us? It increases access to convenience for the client, reduces some financial and time constraints that arise from frequent visits to clinics, reduces stigma, as the recipients of care will be able to select convenient pharmacies, and it reduces workload of overburdened healthcare workers in public facilities, and therefore enabling them to pay attention to those who are in most need. So we have some definitions before we engage in the CPM. We have the hub. The hub is the public facility which will be referring. It will refer the clients, and it is also where the pharmacies will be getting their ARTs from. And then we have the spoke, and the spoke in this context is the community pharmacy, and this is the pharmacy outlet that will be linked to the nearest hub health facility within the same county. Please note that within the same county for the purposes of ordering and receipt of ARV medication. And the pharmacy will be linked to only one facility for ARC supply, but recipients of care can be linked from several health facilities. So what do I mean with this? I mean, if you have a hub, which is the healthcare facility, it has different spokes, that is the pharmacies. So one pharmacy will be linked to one healthcare facility. But now when it comes to referring the patients, one healthcare facility can be able to refer patients to different pharmacies. So what is the criteria of selecting a hub? It is a facility which has more than 1,000 recipients of care. It has an implementing partner support. It should be have a electronic medical record compliant, and preferably we started with government-owned facilities, and should be having healthcare workers who have been trained on the SD model, a facility with a robust appointment system, has a robust monitoring and evaluation system, and it is willingness to participate through approval by the health facility management. So, what about the criteria for selecting a community pharmacy? First, it is based on the client convenience, and then the pharmacies must be able to express their willingness to participate in the model by filling a willingness form. And then the criteria for selection and maintaining pharmacies in the model includes the pharmacy must be registered by PPB, should have the requisite infrastructure, have a registered staff with PPB with valid annual practicing license, should be within 50 kilometers radius from the hub facility. This is for the convenience of picking the medications. We should have, we will also, or we will be looking for the proof of CPDs by the staff. And staff should have knowledge on the management of HIV patients as per the NASCOP guidelines, and have transport capability and willingness to take up recommended Ministry of Health documentation or tools, and then express willingness to participate. So this is how we envision the recipient of care flow. The recipients of care will be informed at the facilities by healthcare workers on model and its operation. Then the healthcare workers will review files for the recipient of care who have expressed interest. And if they are eligible, they will proceed to complete consent form, and then they do the selection of the pharmacy of choice. Then they enroll via the electronic medical record of choice indicating the patient regimen. If they do not meet the criteria, they are supposed to be at the facility. So at the community pharmacy, ART refill, the community pharmacy will be carried out by licensed and trained pharmacy staff. They will receive the prescription, they complete a short ART refill form for each ROC. They will be able to refer to the facility for clinical review if the clients present with any symptoms. They'll be able to check the prescription and dispense appropriately, and then provide medical counseling, and then they remind the client on their next clinical review update. So in case of any losses of ARV medications, the ROC should collect them from hub facilities. That means you are not supposed to dispense to ROC twice in the same refill prescription. So this is just a more elaboration on the same. Healthcare will provide with the list of all participating pharmacies. ROC will be provided with medicine at the point of being referred from the pharmacy. Then it's after 3 months when they will be able now to go and collect their medication at the community pharmacy. So this is how the commodities will be flowing from the central medical stores. Then they flow to the dark blue arrow shows the community delivery. And then because if you don't report, we cannot be able to resupply you. So the light blue ones is showing how the pharmacy is supposed to submit their reports. They will be reporting to the facility, and the facilities will continue reporting using the existing reporting mechanisms. So can a client opt out, or is there a discontinuation criteria? So a client can voluntarily opt out, or they can be discontinued, and this is the discontinuation criteria. One, if the client becomes not established. Remember we talked about established is you being under below 50 ml copies per ml. If the ROC misses any of his appointments by more than 7 days or more, and for the females, if they get pregnant while they are on CPM, and then when ROC exhibits any danger signs, and if they voluntarily just wish to opt out or transfer to another hub facility. Please note that, and we will still emphasize on this, in all cases above, ROCs will be referred to the hub facility. That is the facility where they are coming from. So what are some of the danger signs which will make you refer a client back to the facility? This is if they have suspected TB, that is cough of any duration, persistent fever, weight loss and night sweats, signs of jaundice, persistent headache, severe rash, or if they report that they came in contact with a person, a TB patient or a person with a chronic cough. So how are we going to do some demand creation on the same? First of all, participation in this model is optional, and ROCs will be advised to choose only one pharmacy from the pool of the available pharmacies. And the key consideration to create demand for the model will include sensitizing staff in public HIV treatment facilities, carrying out recipient of care education on the model and the benefits of the service, sensitization and engagement of network of persons living with HIV, creation of mass communication when the service is well established and widely available, experience sharing among the recipients of care who are on CPM, and continuous quality improvement of service to meet ROC's need. And then above all, NASCO in collaboration with stakeholders will be able to develop a communication package. On the health information system, we are emphasizing that data between private and public facilities will be confidential, and all data will be generated electronically, and the system will be installed both at the hub and the spoke. And the system shall be able to provide real-time data entry for client record management, dispensing, stock management, and report generation. And the system will store data from time the pharmacy starts implementing the model, and we shall have user rights according to the levels, and reports will be generated monthly or as per need. So the data shared between the hub and spoke, we have the biographical and the clinical data. On the biographical data, we have the CCC number or the unique patient identifier. We have the age, sex, weight, and the locator information. On the clinical data, it is about the regimen, the dispensing period, dosage, any allergies, and any other medication which the client is taking, any existing chronic conditions, family status, family planning status for women, and then the dates of routine tests, and that is the viral load. So to ensure client information is privacy, or to ensure privacy and confidentiality, client information between the public and the health facility will be shared electronically, and only authorized personnel will be allowed to access the ROC information. So remember, if you are given a password or you have been allocated a user right and you just misplace it or information is leaks out. Remember, we are governed by the Data Protection Act, and community pharmacies or private pharmacies are not exempt to that. So if anything happens, the person who signed up will be held liable for that. So other requirements for parallelization of the community pharmacy model is development of the memorandum of understanding. There is the definition of responsibilities. There is the role of the national, that is NASCOP. There is the role of the county, CHMT. There is the role of the hub facility. There is a role for the client, and also role for the sub-county, the CHMT. And then we have the issue of resource allocation. So we carried out a pilot phase in 5 counties. That is Mombasa, Nairobi, Kiambu, Nakuru, and Kisumu. And we were able to proceed, and we already identified or selected some pharmacies. And I just want to highlight some of the some section of the report from the selection which we carried out. So in the 5 counties, this is the distribution of the pharmacies. In Kiambu, we had 28 pharmacies which expressed interest. Kisumu, 13. Mombasa, we had 7. Nairobi, we had Nairobi, we had 28, and Kiambu, we had 23, and then Nakuru, we had 8 of them. So we were looking to get 10 pharmacies per county, and this is what we were able to check. On the issue of regulatory requirement, I've been able to just pick one of the requirement which we assessed, and was the validity of the premise license. And as you can see, blue indicates the premises which had licenses, and the orange is indicating the premises where we visited and we couldn't find a valid premise license. Kiambu, we had 1 pharmacy. Kisumu, Mombasa, all the pharmacies had valid premises license. Nairobi had 1 pharmacy without a premise license, and Nakuru 2. On the issue of superintended by CADA, the blue indicates those pharmacies which are superintended by the pharmaceutical technologists, and the orange denotes the pharmacist or not superintended pharmacist. And as you can see, in Kiambu, we had 11 out of the 24 pharmacies. We had 11 being superintended by pharmacists. Kisumu, we had 2 which were superintended by pharmacists. Mombasa 2, Nakuru 2, Nairobi 11. In the terms, in the service fees chargeable, because we had asked the pharmacies to indicate how much they are willing to charge the recipients of care once they visit their facilities. You can see the highest figure which most pharmacies indicated was 200 shillings, which had 39.3%. The figures stretch between 100 to 300, but we had some outliers. There are some pharmacies which indicated they will just offer the services free of charge, and we have some pharmacies which had indicated they will offer the same. The highest quoting pharmacy had quoted a figure of 350. So this is the pharmacy distribution. Of course, it's not very representative because we had only concentrated ourselves in 5 counties. But if I drill down to counties, this is how the distribution is in Mombasa. And you can see how it's the rest in the other counties, that is Kisumu, Nakuru, and Kiambu. So, in conclusion, the selected pharmacies will be mapped to various public health facilities, and we were able to do some capacity building, of course, not comprehensive. Capacity building will be a continuous process. And then the 50 community pharmacies which were selected are eligible to enter into MOUs with the county governments for implementation of this model. And then the public health facilities, healthcare workers will support in recipients of care selection, referral, and demand creation. The reason why we indicated the MOUs to be signed between the county governments and the pharmacies is because, one, health is devolved. Number two, for easy of supervision, and also the easy of reporting, and also to assist maybe when there is terms of when some support is required, and also by signing a MOU with the county governments, it means the implementing partners in those counties can be able to support the community pharmacies and continue with the engagement. So what are our next steps in this? We will have the signing of MOUs. We are here to have any pharmacy or any county sign MOUs, but we have been informed that Nairobi and Kisumu are a bit ahead. So we expect to have some traction on that bit. And then after that, there shall be commencement of operations. And then we are also anticipating scale up to more community pharmacies within the 5 pilot counties. And then we want to move or incorporate more other counties as we continue to learn from the pilot that was in Gishu, Kakamega, Kisii, Nyeri, Embu, and Machakos. And then as per our private sector engagement framework, we are envisioning scaling up of those services. We want to start offering pre-exposure prophylaxis through community pharmacies. We want to offer post-exposure prophylaxis through community pharmacies. We want to do the lab, that is either sample collection or at the community pharmacies. So I want to acknowledge the county governments. We are very grateful to the CHMT, that is the county AIDS coordinator and the county pharmacists, and the county healthcare workers, that is the facility of the workers which we engaged. We acknowledge the network of people living with HIV NEFAC, professional bodies, KPI and PSK. They accorded us a platform where we're able to engage their members. PPB has been on board in the development of this framework and even in the development of this community pharmacy model. We will also furnish the Farmers and Poisons Board with a list of the pharmacies which are keeping the ART medication, so to ensure that once they are doing the inspection, those pharmacies are not criminalized to possess government stores. Then we have the implementing partners, PEPFAR, Bill and Bill Gates, and we have the ARC, African Resource Center, and then of course we have our development partners, CDC and USAID. Thank you all. Back to you, Dr. Ezron.
All right, thank you so much, Dr. Eric, for that insightful presentation. So we're just going to jump right into the Q&A session, and Dr. Anita will be assisting on that. And just before that, I'd like to encourage everyone, if you have any questions, kindly type on the Q&A chat, and they'll be addressed by the speaker. And just to note, you don't have to send your email address on the chat. We already recorded your attendance once you logged in into this session. So don't send your email address on the chat. So Dr. Anita, kindly take over. Thanks.
Greetings, everyone. Good evening. Thank you so much, Dr. Eric, for the wonderful presentation. There's a few questions. I'll start with the first one. How long does a CD4 count take? Also, for a recently tested positive client, which is the best place to do all the other required tests before starting ARVs? Please let me know if I should repeat.
Dr. Anita?
Yeah. Sorry, am I audible?
Yes, yes. So how long does
Okay.
a CD4 count take? Remember when the HIV treatment started, there was the CD4, there was a baseline CD4 test which was being carried out, but we moved a step further when we started to do test and treat. So in that case, the issue of CD4 was a bit left behind, but with that, we are now seeing the emanation of opportunistic infections creeping back, and now we want to go back to the management, which is leading to advanced HIV disease. If you look at the WHO guidelines, there is a well definition of what constitutes advanced HIV disease. But now we are going back to that, whereby we will be ensuring that all clients who present or manifest with some conditions, their CD4 is normally carried out. And then the question was also asking about the best place to have the people undertake their tests. For HIV treatment, I think the government facilities or the public health labs, they normally are well equipped for that. And this is well devolved because we have the regional referral labs, and also some of the county referral labs are able to undertake such tests. And even going further down, we have some sub-county and level 3 facilities whereby we have the government supplies commodities, and they are able to those tests are able to be carried out in the facility, like the issue of early infant diagnosis. You just take a dried sample and then it is shipped to the labs. It's tested, or the tests are carried out, and then we have a very elaborate lab manifest whereby your results are just keyed in there, and then at your facility, the provider is able just to key in your unique identifier number, and the results they can be able to access the results. Thank you.
Okay, thank you for that response. There's another question. Will services and HPTs for HIV in community pharmacy be charged?
So as I've indicated, the products will be supplied from the government through the linked facilities. The linked facility, we have called it a hub, and it's through this hub whereby those community pharmacies will be able to access those products. We will not charge the patients of those we will not charge patients those commodities, but the pharmacies, as I've indicated, they indicated a service fee which they will be able to charge the clients just for the time they have utilized to offer the service.
Okay, great. Thanks for clarifying that. Another question. By pharmacy staff registration, are there any specific measures to ensure that quacks will be curbed?
Yes, thank you. Yes, that's why we are our entry model to this to the CPM is through the professional organization, that is through the KPA and PSK. And number two, when we are sharing out the pharmacy or the willingness to be onboarded in this model, we normally send it to both the professional organizations, which in turn sends out the call to the members. So if a quack is able to get a registration or to be able to be onboarded in this model, it's through the aiding of some of the professionals, because how will a quack get a link which has been sent through the community or through the professional bodies? Number two, we normally carry out an elaborate assessment. We normally go to the ground. I remember when we started this model and we were visiting the community pharmacies, some staff, they were shocked because they told us, we thought you will come in next year or will be coming in the next 6 or 8 months, because we are used to government not being efficient, because we just after guys had sent their responses, we sent an email and indicated that we were going for the assessment. And number three, when we are doing our assessment, we ensure that we have the sub-count pharmacist with us, and if possible, we also ask for participation of the regional office bearers for the professional bodies, so that they can witness whether we are doing a fair process. Thank you.
Wow. I'm loving this. There's a lot of questions here. Let me just go back to the chat box. Somebody asked, is the service fee going to be harmonized, or is it subjective to a particular pharmacy?
We have not thought of harmonizing, because even for us, when the recipient of care will be choosing a particular pharmacy, all the information will be disclosed to them. They will be told, we have pharmacy X, it's charging 200 shillings. We have pharmacy Y, it's charging 300 shillings. So it will be upon the client to choose the pharmacy which they feel comfortable with.
Okay, thank you for clarifying that. Back to the Q&A section. Somebody asked, how do pharmacies do follow-up on clients dispensed ARVs? How do the pharmacies do follow-up for clients, I think, who have been dispensed with ARVs?
Remember, the patients we are sending to this model are well established, are those who are established. And established, as I indicated in my presentation, is these patients, they don't need supervision for them to be able to undertake the medication. And you'll be able to do a follow-up once that client comes for a refill the next time in your pharmacy. Yeah.
Okay, thank you. somebody said, great presentation and concept. I had the privilege of participating in the design and implementation of the CPM in Mozambique with less than 19K ROC benefiting. There is great opportunity for expanding access to ART. Did you consider acceptability of among PLHIV stroke ROC for CPM?
Yes, we did. When we were coming, let me just say that when you are offering HIV services, this is one of the services which you can't offer without having the client at the center. And even in our PSCF, you saw at the center we have our client. So as we were developing all these things, we involved them, and they have a complete a full module of community sensitization. And in all our meetings, we have been involving them and informing them on the same. Thank you.
Okay. Another question. Mine is to request if that the slides can be shared with me, please. I think we can organize how the slides can be shared, maybe through Hezron, and then he can share to all the emails. Another question, what is the minimum dose of PEP if you can not take for 28 days?
So, Dr. just before you move on, I can see there is one question from Martin Kamala, who is asking, how will you tell if a patient come with CD4? I don't know whether he wanted to indicate if a patient comes with a CD4 count less than 200. So this patient should be referred to the hub facility for further management. If he meant to ask, how will you be able to carry out a CD4 test? This CD4 test can be carried out free of charge in any public facility which is offering, public or private facility or faith-based organization facility which is carrying out the ART services. So the issue of minimum dose of PEP if you cannot take for 28 days, I don't know whether we have studies which have shown you can be able to take less than 28 doses of PEP. I'll be able to look into this and maybe revert in a future presentation.
Okay, thank you. So I'll go back to the Q&A section again. How will the report on the consumption be done in a pharmacy level while the merging with the facility in that region, stroke sub-county?
In my presentation in the health information
so he's basically asking at the pharmacy level, how will they report? Yeah.
Yes, they will report through the EMR, through the platform. I hope in future we shall be able to come and demonstrate how the system will be working. So as we move on, we shall be able to demonstrate that, but they'll be able to report through the electronic medical record system to the facility, or they'll be able just to have a printout and then take it to the facility for a refill.
Okay.
Any other question, Doc?
Yes. There's still a couple. How much will the patients pay? Is it dependent on individual pharmacy or is it a set fee? I think I'd already addressed this. Dr. Ann is asking, will the pharmacy personnel be empowered to offer services such as adherence tracking, or will the services end at dispensing?
Maybe I skipped that bit, but one of the consideration we were making as we were onboarding these pharmacies was availability of a dispensing room, a consultation room. So any patient counseling you want to undertake, you'll be able to undertake. It's not limited to just the ART dispensing, but you are free to undertake any extra services, including medical adherence counseling and even the issue of MTM.
Okay, thank you. I hope that's clear. Somebody is asking, in this model, are the laboratory services and clinic follow-up exclusive to the hub facility, or are they decentralized to the pharmacists?
Come up again.
In this model,
yes,
are the laboratory services and clinic follow-ups exclusive to
Doc, are you there? So maybe I can answer this one for when do we expect inclusion of other counties now the third priority is given to scaling up to other community pharmacies in the pilot counties. No, we have not said the priority is scaling up. We have just said now that we have started on the 5 counties, the county pharmacies or the CHMTs and the implementing partners are now free to onboard other pharmacies in the same counties as we move on in the other counties. Of course, it will not be a systematic manner or introduction of the same, because I know at some point after the concept has been grasped by majority of us, we shall be able now even to move full throttle in the country. So we are just prioritizing as per the resources available. On the issue of concerns of deviation of the medicines, yes, this is a consideration we have made, and we shall use the existing supervision mechanisms. And also, number 2, remember when you are doing your reports, just like the facilities where your patient numbers have to tally with commodities, that is also a tally we shall be doing. Then number 3, we also are expecting the staff and the personnel to exhibit some bit of professionalism on the same. And we have said we shall continue doing out CQIs, that is continuous quality improvements, to ensure we are able to tighten or close any gaps which have been identified. Thank you.
Okay, thank you. Kindly, if anyone has any other questions, please retype them on the Q&A section. Dr. Eric, are you still able to see other questions that haven't been responded to?
So the last question is about any curative drug of for HIV. I can't speak authoritatively on this about a drug which is either passing clinical trials. What I know, we are having some advancement in the prevention. Remember, we have the cabotegravir, long-acting injection, which is injected after every 2 months. And now we have lenacapavir by Gilead, which shall be injected once in every 6 months. But that one we are a bit far in implementing. What we know we have data for is the cabotegravir. Thank you.
Thank you. Last question. Are you only going to use KEMR, or will you link with the web ADT in terms of tracking commodities?
We had anticipated to start with the EMR, and if so, we shall explore other mechanisms of how we will be able to undertake the same. The reason why we chose the Kenya EMR, I think one of the consideration was the smooth operation between the clinical and the pharmacy, because remember, when you are referring an ROC, they should be referred at the clinician level. And the clinicians side in the CCCs, most employ the EMR, and the pharmacies, they use the WebADT for dispensing. But we are still at, remember this was a pilot phase. So if we can, we can see the interoperability bit between the EMR and WebDT functioning, then why not we can use it?
Okay. Somebody is asking, how are you going to ensure fair distribution in terms of ROCs choosing the pharmacies?
This one we can't determine because, as we have said, the king is the ROC for them to identify and to have a preference, to identify their preference. I have not also indicated the results of some of the questions we ask, because one of the consideration is about the operation time. Remember, most of the facilities close at around 3 for CCCs, and they are not opened over the weekends. So one of the convenience which the recipients of care are looking for is there a pharmacy which can be able to operate at those two extremes, open in public holidays, open till late, open at over the weekends. So those are some of the considerations which the pharmacies will be able to outwit or compete with each other.
Hey, Doc, the questions are many. I think I'll just take the last 3, and then maybe the others, they can contact you. So Dr. Andre is asking, any considerations for monitoring and documentation of ADRs through participating pharmacies?
Yes, thank you. That is why maybe I've omitted it in our presentation, but it is pharmacovigilance is key to us in community pharmacies, and it is one of the things which we shall expect the community pharmacies to play a pivotal role in doing.
Okay. Another question, what informed or inspired this move into community pharmacies? Will these clients get the same level of care as done in the hospitals? I believe you've answered this one though.
Yes.
Maybe you can just repeat the question, the answer, because I think there's 2 of them. There's 2 questions on the same.
One is, first this one is coming from the recipients of care perspective. Remember, when I was doing my presentation, I was able to show about the differentiated service models which are existing. And as it is, most of the patients, all the patients which will be on this model are the established patients. So these are patients who only visits a facility once. They go to the clinician once and get a 6 months prescription. And the next time now they are coming to the facility is for them to have their VLs being for the withdrawal of the VL sample, and they get a 6 months prescription. So these are established clients who don't need much of the attention of the patients. But remember, we have also an elaborate discontinuation criteria, and we have the opt-out criteria by these clients.
Okay. Dr. Joseph is highlighting that the Kenya EMR doesn't have the dispensing bit.
Yes, I think Kenya EMR have developed a dispensing model, and as they move, they want to move to the whole hospital setting operations, a model a module they want to launch. I think they have been able to develop a dispensing module for pharmacy.
Okay, thank you for highlighting that. So it's yet to be launched, so I'm sure it should reflect soon. Last question. Any maximum prescription period 30 days, or can it be 6 months DCM?
And maximum prescription period is that days, or it can be. Yes, we have indicated it is 6 months. You get a prescription of 6 months. So at the point of referring from the hub, you will get a prescription of 6 months. And then The first 3 months you get the drug at the facility. Then when you are going for a refill, it's when now you'll be able to go to the community pharmacy instead of going back to the hospital.
Okay.
Yes.
Guys, I hope all questions have been answered. So just an overview of the project. This is a project PSK is working with NASCOP and JAPIGO to have PrEP and PEP easily available in community pharmacies. So they're currently at the study stage. NASCOP is handling about 50 pharmacies. Is it 50, Dr. Eric, or 60? Okay, I think it's about 50 to 60 pharmacies among all counties, among 6 or 5 counties, to see how viable the acceptability of offering ARVs, PrEP and PEP is in to the community. So once they're done with the study phase, then we'll move on to probably training of the pharmacists on how to offer these services. As he has gone through on the criteria for you to be viable, there's the willingness, of course, there's the availability of space in your community pharmacy to offer consultation. Again, remember the charges is up to you as a pharmacy to decide. So you can either charge 200, you can either charge 300, 350, or have it for free. The commodities will be offered for free as you'll be linked to a public facility. So hopefully once the study phase is done, in next year, then we can have the rollout by starting with the training and then offering the commodities, and the clients will, of course, know you guys as service deliverers of ARVs, PrEP and PEP. If any questions, maybe lastly, you can ask on the comment section. I think everything else has been touched on when it comes to reporting through the KEMR. What mechanisms have been put in place to ensure clients of PEP are not overcharged? We are only charging the service as the commodities will only be offered for free. Again, this is also we can't control how a person behaves when commodities are given to them for free. So it's just a matter of character and trust in the pharmacy as a profession. So yeah, I believe we've come to a close of the session. Thank you everyone for joining. Apologies for the confusion in the timings. But we hope to rectify on that. Dr. Hezron has requested that you don't have to write the CPD, your emails for CPD points, as it was already taken up when you are registering for the webinar. And I think we can have the presentation shared to Hezron, and then he can share to everyone else. Dr. Hezron is back, so he can close.
So, Doc, before you close, I think there's a question which has been put across here. What is the rationale for providing PrEP meds in terms of dosage, frequency of use, and how to use prior to expecting exposure? Maybe this is something which can save somebody this night. Let me just allow me to project something.
Sure, go ahead.
Yes, allow me to project something. Just a minute. And as you have indicated, Daktari, remember the issue of PrEP, JAPIGO they were doing a study. So when it comes to onboarding or the complete implementation of this, we want to ride on what we shall have done for the ARV distribution. I think I have something. I don't know whether it's visible now.
Yes,
is it visible? Yes. So there's someone who has asked about a PrEP, and PrEP. We have different forms of PrEP, as we all know. We have the oral PrEP, which we are currently implementing in the country. Then we have the use of the ring, and the cabotegravir. But here now we are talking about the oral PrEP. And remember, the oral PrEP, you can either use it as a need be, which we call it the ED PrEP, event-driven PrEP, the ED PrEP. That's what we abbreviate ED. And then we have the continuation PrEP, which you can use. For the population of people assigned female at birth who are using oral PrEP to prevent HIV acquisition during sex, for those who are taking the oral PrEP, it's daily. Take a single dose daily for 7 days. And remember the correct medication for PrEP here we are referring to TDF FTCT. That is tenofovir dolutegravir, tenofovir disopropyl fumarate, and emtricitabine. That is the first line PrEP drug we have, or you can take TDF 3TC, tenofovir plus the lamivudine. So they are supposed to take 1 dose per day. So stopping, the stopping is after a single dose is taken daily for 7 days after the last potential exposure. PrEP can be stopped. And you can see event-driven PrEP is not recommended for this population. Then we have people assigned male birth. Remember now we have people who are referred to male, but they were not assigned the male birth. They were not assigned male at birth or female at birth, and who are not using estradiol-based exogenous hormones and using oral PrEP to prevent HIV acquisition during sex. They take a single dose daily for 7 days before the potential exposure. And then when they are taking 1 dose per day, and then how can they stop? It is after a single dose is taken daily for 2 days after last potential exposure. This is for male is after 2 days, for female is after 7 days. And then if it's event driven, take a double dose 2 to 24 hours before you have an event, before potential sexual exposure. So this is the dosing, this is the loading dose, and should be taken, that is 24 hours. So the earlier the better. And how can you stop? After a single dose is taken daily for 2 days. So you'll take 24 hours before you have your event, then you continue with the ED for 2 days after the last potential exposure. Then the people using oral PrEP to prevent HIV acquisition from non-sexual exposures. So these are people who inject drugs. You take a single dose daily for 7 days before potential exposure. Then when can you stop? You can just stop it after a single dose is taken daily for 7 days after the last potential exposure. Then PrEP can be stopped. So event-driven PrEP is not indicated for this. Yeah, so that's what I can say, Dr. Ari, for that.
Okay, thank you. Doc, I kindly request if you can take just 2 more questions. I feel they're burning.
So you can... Okay, so
Dr. Laz is asking, suppose the clients reduce in public facilities at the expense of community pharmacies, will there be implications?
I cannot predict that today, so maybe we shall be able to have it as we move into the model and see how successful it is. If more clients go to community pharmacies, it will be able to show the impact community pharmacies or pharmacists are able to contribute towards public health care in the country.
Okay. The last one, in the training, PEP and PrEP were excluded. Are you saying they're part of the package?
No, they are not part of the package. That's why in my next steps, I said we shall be able to onboard such.
Okay, thank you.
Thank you. Let me appreciate everyone who joined, and I hope we shall continue to have more engagements on matters of HIV care in the country. Thank you. Back to you, Dr. Anita.
Okay, so thank you everyone for joining as well. Apologies again for the mix-up in the timings. I hope Hezron can clarify on the CPD points for those who joined at 7. I'm not in the best position to answer that. And again, I'd just like to say thank you. If you have any questions, please feel free to reach out. I think my email is attached on the webinar. And yeah, thank you.
All right, thank you so much, Dr. Eric and Dr. Anita, for running through that session. So we've reached the end of the session, and again, we want to apologize for the mix-up in the timing. I know we usually have our webinars at 7, but this time round, we had scheduled it to happen at 6 p.m. so that we end early. So for those who've missed out on the previous part of the session, we're going to send out the recording together with the CPDs and the slides. So kindly be on the lookout for that. And for the tokens as well, you'll be getting them. So just briefly before we close, Dr. Amos, maybe if you can go to the next slides. So I'd like to remind you about some upcoming webinars. And the first one is this, which is on dissemination of the Kenya National Pharmaceutical Policy Evaluation Report and preparation for submission towards policy review. So we'll be having a 3-series session of webinars, and the first one will be happening on 17th. The next one will be happening on 24th and 26th of September. So kindly be on the lookout for that, and ensure that you read the policy, which we had shared out on email and on the WhatsApp channels. Next slide, please. The next one is on World Patient Safety Day. We'll be having a webinar in collaboration with the CAPI and the Pharmacy and Poisons Board. So this webinar is scheduled on 17th as well, but it will be happening in the morning at 9 a.m. So kindly take note of that. It's happening on 9 a.m. while the other webinar is happening at 7 p.m. Next slide, please. This is another activity that will be happening, still commemorating the World Pharmacist Day, and this is by Tana Adi branch, where they'll be having a walk in Kiambu, level 5. And then after that, there'll be a lunch at Camilla Gardens. So for those from Tana Adi branch and those surround, you're welcome to attend the event. Next slide, please. Then on 23rd to 26th of September, again, we'll be having a series of webinar for the Global Pain Awareness Week. So kindly be on the lookout. We'll be sharing the posters and the links for registrations for this webinar. These webinars are going to be supported by Helion. So be on the lookout for that. And finally, the last item is the World Pharmacist Day and Family Fun Day activity. This is going to be happening on 29th of September, which is on a Sunday. So tomorrow is going to be the deadline for registration for those who would like to get a t-shirt. Remember, we need to get the registration and the sizes early so that you can process the t-shirts in advance. So if you've not registered yet, kindly do so. And for those who missed some of the merchandise during the conference, this is where we'll be giving the merchandise that you missed. So kindly ensure you attend and register in advance so that you get your t-shirts. So I think that's the last item. Thank you so much for joining this session, and we look forward to having you in the upcoming sessions. And if you've not subscribed, all the events that we've been posting, all the webinars that we've been posting the last few days, all of them are on the PPB portal. So kindly ensure that you subscribe early. Thank you so much, and have a good night.